Good morning. Let's get things started. So hopefully you can all hear me, and hopefully my voice holds out for the next couple of minutes. So good morning, everyone. So I'm Nadia Krellin. I'm a fellow at the Nuffield Trust. I'm part of the NIHR Rapid Service Evaluation team, and we're really delighted that you're all able to join us here today at the 2025 Rapid Evaluation in Healthcare Conference. On behalf of the Health Foundation and the Nuffield Trust, we'd like to extend a warm welcome to you all. In terms of the theme for this year's conference, it is making the most of digital, rapid evaluation and new technologies in health and social care. So we know that new technologies are rapidly emerging in health and social care, and they're bringing a great deal of hope and expectation, from the use of AI in diagnostics to the expansion of digital health records. The shift to digital offers tremendous opportunities for a fundamental change in how healthcare is delivered. However, the shift also does present substantial uncertainty, and despite much excitement and investment, we've seen relatively few examples of successful implementation of new technologies at scale. So the ability to provide robust and timely evidence and to make effective decisions is essential for the adoption and for the benefit realisation of these technologies in healthcare services. Today's conference aims to bring together representatives from the rapid evaluation community, so including analysts, evaluators, service users, policymakers, commissioners and local decision makers, to really focus on the role of rapid evaluation to make sense of these new technologies and to provide a forum where we can discuss opportunities but also challenges that they bring. So what do we have in store for you today? What can you expect? So shortly I'll be handing over to the chair of our first plenary session. The session will start by setting the context and exploring the broader health and care landscape in which digital innovations are being implemented. And then after a short break, you'll have the opportunity to choose between 3 breakout sessions. The first will be a workshop that aims to bring together the perspectives of suppliers and also users of evaluations, and will include discussions of what evaluators can do to support decision makers and decision making. The second session will focus on equality, diversity and inclusion considerations in rapid evaluation, and then the third will be a practical session using AI as a tool in evidence synthesis. Following lunch, our first afternoon breakout session will be another workshop focused more on the challenges of evaluations of digital technologies. Excuse me. The second will focus on drawing lessons from an NIHR-funded evaluation of AI in lung cancer diagnosis. And then the third session will explore strategies for unlocking the potential of data from new technologies. We'll conclude the day with a final plenary session back in this room, which will be a forward-looking discussion about the future of new technologies in healthcare, where we're headed and how rapid evaluation can help us get there. So just a quick few housekeeping notes before we get going. We ask that you please use the hashtag rapid evaluation to share any thoughts via social media. The plenary sessions today will be recorded and will be available after the conference. For the plenary sessions, we do have roving mics on hand. When you have a question or a comment, please raise your hand, wait for the microphone, and then please introduce yourself and your organisation before speaking. One of the most valuable aspects of this conference has always been the connections made between attendees. So please do make the most of the breaks throughout the day for networking. We are able to use the courtyard today, which during the breaks, and obviously the weather is glorious. So please do take the opportunity to get some fresh air and enjoy the sunshine. Please do take a moment to look at your programs and decide which breakout sessions you'd like to attend. Note that the 2 workshops today that are focused on navigating the digital maze complement each other, but are also standalone. So you can attend both of the workshops or either of the workshops, depending on your preference. The workshops will be an opportunity to discuss topics through facilitated table discussions, and we will have scribes that are taking notes that will be compiled into a published output after the conference. Also, just a note about the practical session, using AI as a tool for evidence synthesis. To attend this, you will need a laptop or a tablet in order to take part. There's also an optional lunchtime session that starts at 1:15 for researchers who want to use ethnographic approaches on short timescales. The newly developed Prepare guidance will be shared at this session, so if you're interested, grab some lunch and head to the Paget room, which is next to the lunch area. Just a reminder about phones, please do check that these are on silent. And finally, if the fire alarm does sound, it is not a test. Please leave the building via the nearest exit, and obviously we'll have staff on hand to guide you if that does happen.
Thank you, Nadia, and welcome everybody. Really excited about the conversation we're about to have with our great group of panel members. Put your hand up if this is the first time you've been to this rapid evaluation conference. So, wow, that's really exciting that we've got a new room and new connections to make. You are all particularly welcome, and we hope that you enjoy the day and get an opportunity to participate in some of these pieces. As Nadia said, a lot of this is about connections and conversations. So we're going to hear briefly from each of our panel members, and then we want to come to you for some questions and discussions from the floor. So as they're speaking, have a think about what are the topics you want us to be covering in this discussion. I'm going to ask my panel members to introduce themselves, and then I'm going to give a little bit of a sort of starting context, and then pass to Kendall for his presentation. Kendall, welcome to the panel.
Thank you. Good to be here. Hi, everyone. I'm Kendall Jamieson Gilmore. I am working in the Systems Strategy Unit at the Department of Health on the 10-year plan. Primarily, I focus on the kind of research, innovation, life sciences section, but it's quite cross-cutting. My day job is at NICE, where I'm Associate Director of Strategy.
Thanks, Kendall. Mindy.
Hi, I'm Mindy Simon. I'm the co-director of the NHS Innovation Accelerator. And if you've not heard of the NIA, what we are is an enabler of innovation and supporting the health service to understand how to work with innovators and how to procure innovations effectively and that are great innovations.
Thanks, Mindy. Sonja.
Hi everyone, I'm Sonja Marjanovic. I lead the Healthcare Innovation Portfolio around Europe, the Not-for-Profit Policy Research Institute, and co-lead a rapid evaluation centre called DECIDE that focuses on tech-enabled remote monitoring and associated tech-enabled care.
Thanks, Sonja. And I think there's a lot of things already that are in my mind around. So we've got the 10-year plan, which, Kendall, you're working closely on. Mindy, this is the 10-year anniversary of the NHS Innovation Accelerator and your largest cohort of innovators. And obviously, DECIDE is looking at new ways of how do we evaluate those technologies. So super interesting. Making the most of digital challenges. That cannot be a more sort of current topic. So I think we've all seen there are huge changes in how we deliver care and how patients interact with care and how the public interact with their own health. There are massive opportunities. I'd suggest that some of those are not new. So I don't know how many people have received patient letters about their appointments. Do we still need to be doing that? Are there opportunities for us just to catch up and get some of the basics right across our health system? I'd suggest yes. Tech-enabled services, creating new ways to deliver care, is a really growing field, and it's really exciting to see some of the boundaries of what we can do to mobilise more efficient services, think about who are the workforce that really need to intervene at different parts of the pathway, and where are there opportunities for mobilising patients to take more ownership and be empowered to lead some of their own journeys through remote monitoring, patient-led diagnostics, interactions with the health system in different ways. So there are a lot of shifts that are happening. There's also opportunities to gather data, and I guess as the lead of our rapid service evaluation team, that's of particular interest to me. And what can we get from some of these new data sources, be that apps, be that the NHS app, which could be another big push in the future direction of the NHS, and how do we use that data to listen and learn about what matters to different audiences, about the success or not of different kinds of health interventions, and how we might respond differently to that. So looking forward to this conversation, I'm going to pass to Kendall. I know we can't have too many spoilers on the 10-year plan, but looking forward to hearing what you can share with us.
Great, thank you. So yeah, I'll give a bit of a run through of the process and what we're hearing in the 10-year plan. As you're aware, it's not published yet, so nothing's final till it's final. So I'll kind of talk through some of the themes, but can't be overly specific. It'll be coming out after the spending review, which will be out in June. But it is in a kind of near final stage, I suppose I'll say. So, as I'm sure you're aware, the 10-year plan has been a commitment from the Labour government. This is on the back of Lord Darcy's independent investigation, which kind of gives a diagnosis, and then the 10-year plan is kind of setting out how we'll deliver that. So what it needs to do is set out how we'll recover kind of core operational services, but also it is a 10-year time period, so it's also about how we will transform and invest over a longer time period so we can take advantage of these new capabilities which emerge and kind of respond to changing kind of demographics and so on. And as part of that, it's going to deliver 3 shifts, I'm sure you've heard about. So hospital to community, obviously long been talked about, hopefully we'll get it right this time to kind of shift resources and ways of working into communities close to people's homes. Analog to digital, obviously a core part of today. We know that we're really behind on compared to other health services and how digitized and digitally enabled we are. And then also on sickness to prevention, you know, it's really the only way we'll have a sustainable health system in the future is if we have much greater focus on prevention. So as I say, it's going to be looking at now, but also longer term. It's been delivered through a big co-development, which I'll talk through a little bit. And it sets, as part of a wider package, including the health mission, which is kind of looks more holistically at how health can be embedded across government, as well as separate work on social care, which is also kicked off. So in terms of the engagement, you know, there was some great work going on from the department and working with Kaleidoscope and with Thinks, so through online engagement as well as in-person events, so over 250,000 online responses, ranging from very practical things to suggestions to make a picture of a dog, the NHS flag, or to shoot the Secretary of State out of a cannon. But they're all being looked at, they've all been reviewed, and they're all being fed into the kind of the hopper. Loads of events, so you know, over 4,000 staff in the public at workshops and events. Some of you may have participated in them yourselves. You know, over 1,500 organisational responses, and a lot of focus on engaging in communities as well. So you know, over 17,000 people have been attending workshops across the country, which have also been attended sometimes by ministers or by senior officials, and also there's kind of workshop in a box models where people can do their own community events and then share the insights back with the plan. As I say, it's all been looked at, it's all feeding into our understanding of what people think about the themes of the plan. It started off quite a wide engagement, really, what people value and what they care about, and then as it's progressed and the plan has become more certain, we've been able to test elements of the plan with the public directly. So the themes that are coming through that work are, well, people are really proud of the NHS and they believe in the principles, but they're worried that the basics not being delivered, and I'm sure that will resonate with all of us. The big kind of headline challenge is on, you know, the key standards of access, so GP services, A&E, and dentists is really coming through strongly. You know, people feel that the system is failing if they can't get an appointment. And a long-standing theme you'll be familiar with is a lack of coordination for those who have the greatest interactions with the health service. And it's not just about patients, of course, also staff. And we know staff are really feeling kind of worried about their ability to deliver standards and the care to the standard that they would want to be doing so, and that's affecting their well-being and stress at work. So we really have to deliver for staff as well as for patients. On the 3 shifts, people are supportive of the general direction. I think everyone agrees that they are logical and sensible things to do. Where things come through with more nuances, hospital community, people are supportive, but they want to make sure that care is going to be safe, delivered to the same standards as it would be in hospital, and therefore it needs to be enabled by, you know, effective ways of working, including the digital and data infrastructure to do so. Analog to digital, you know, Jenny, you mentioned getting the basics right. That's really been a key theme from patients and staff. There's lots of exciting things that we can be doing, but first we need, you know, joined up data. People can see a record. They need an IT system that doesn't take 20 minutes to turn on. So we have to get the basics right before we can start overlaying some of the more exciting things. And on sickness to prevention, you know, we really have to look at the root causes. It's not just about what the NHS does, it's around wider society and how we work to keep people healthy. So that's kind of just touch on those themes there, but, you know, we're not getting the basics right, both on digital, but also more widely on access standards. But that doesn't, people don't think that needs fundamental change, but actually when you look at some of the trends and the workforce and the demographics assumptions and so on, there are some big things that we need to change to get right so we can get the basics right. On access, we think technology is really essential and important to that. There's different views within the public about exactly what that means in terms of, you know, face-to-face versus digital access and the role of AI and so on. And shift to hospital communities, again, people think it's convenient, it makes sense, but as I said, they're worried about, will that maintain standards and safety? I might just skip this slide for the things. So in terms of the themes which are coming through, and I'll try and give a bit of a digital overlay on this, which can be partly with a DH and partly with a nice hat on. So neighbourhood health services are a really core part of the plan. So this is about the shift from hospitals to community, and that will be delivered through having a neighbourhood health service where more care is delivered locally, close to people's homes. So therefore, you're going to need to have, access to information for staff so they can understand the full state of a patient's health. They can, access records which might be from other parts of the system. They can use that to inform, diagnostic prescriptions and so on. So you need the data flows to be there, and you need to have the kind of workforce models where people are digitally enabled with the back office which supports them so they can go and work in different settings and more flexibly. Patient power, so that's a really key theme coming through in the plan. People should be able to choose, but not just talking about like choosing where they have elective surgery. It's more around having proper information about their own health and their health status, but also around their experiences, and that can be viewed by everyone together. They can give feedback where it's appropriate, and that's where the app comes through as a really key element. We know it's really widely used by the population. There's more to do that we can build on the app as a way for people to have more convenient access to services and to access the data and to share that back with clinicians and health professionals. All this needs to be enabled by culture and workforce, so there's things around leadership and training and development, including how you would be using new tools. And as I mentioned, that needs to be enabled by flexible workforce models, which will be underpinned by the data infrastructure, the digital services, so that they can work productively, rostering. There's a lot of transformation potential in back office through the use of digital and over time AI. Science and technology, this is the bit that I've been mainly looking on. So we know that there's huge potential of some of these products coming through. Could be transformative to keep people healthy, to do more proactive and preventative care. We know also that the NHS has historically been not always a great customer of some of these things. It's quite hard to go from developing a good product through to scaling it in the NHS. And that leads to problems both for patients and for staff, but also for the wider economy. Innovators are growing great products here, then they're having to leave because they can't scale through the NHS. So we want to make sure that the NHS is a great place to launch products, and that includes the ability to evaluate them to show that they work and demonstrate efficacy and cost effectiveness more widely. And then finally, that's going to be underpinned by more of an operating model which supports these shifts. So it's about local power and accountability to patients rather than upwards to ministers. So there'll be some thinking about how the operating model supports that system focus, local focus, patient focus, rather than upward reporting. You've already seen some changes around the national bodies to reduce kind of administrative oversight and focus on governance. And I think I'll pause there. Just, I guess, briefly just from the NICE side. NICE is going to be really important to many of this in terms of looking at the products that come through, making sure that they are robustly evaluated, and so therefore, particularly on the digital health tech side, there's huge amounts of things coming through. So there's a focus on, well, how does the health tech appraisal program and the guidelines program have the capacity to evaluate those products, thinking about the balance between evidence and risk so that things can be rolled out and evaluated effectively, but making sure that the regulatory status is clear and so we need a really clear kind of pipeline from regulation through to a robust, nice health tech assessment through to adoption with ongoing evaluation where appropriate.
Thank you, Kendall. Super helpful. And I guess with the NHS app being a core part of the forward plan, actually how NICE feeds into some of the evidence-based content that might go onto the app will be a really interesting part to watch. Mindy, over to you.
Hi, so it was really great to hear Kendall acknowledge that it's really difficult for innovators in the UK landscape. I didn't want to, though, kind of harp on about that because I think we all know it's a bit difficult. I want to kind of touch upon some of those pieces, but also show that there's really positive bits happening and things that could happen, and I think that we can all come together to make happen. So I think it's really kind of clear that there's so much technology out there, and we're in an age where it's transforming our lives, and it's sort of obvious that it's going to help in those three big shifts. And that can only happen, though, if we all work kind of together to make innovation kind of predominant within our landscape. I think there's always a misunderstanding from people about innovation, and I think that holds us back. I think in this room, we're all going to have a kind of really reasonable understanding of what innovation means and what that entails. But I think there's a more general perspective in the public that innovation means big, shiny things that are brought out by big players and household names. And I think that we all know that's really not true. I think innovation can simply be any small, simple change. And I think those simple changes are things that are going to really shift, particularly that digital to analog. And that's happening every day in what we're doing anyway. So I think we need to encourage innovators to stay in the UK to help with those really simple changes. There's a lot of innovation out there at the moment that's really pioneering and game shifting that's coming from within the UK. But a substantial amount of this, or a number of these, are from small organizations. So you're not thinking of big household names like Google, Microsoft, etc. They're names that you'll kind of never hear, and that until I was in this field, I never heard of. And I think, one of the problems is the size of these companies can make it really kind of difficult for them to thrive in the kind of current healthcare landscape. And it's not just about the funding, but it's also about the capacity within the healthcare system to engage with innovation. So we need to kind of create the landscape that allows people within the NHS to work with innovators. And that's a hard one to do. It's by releasing the capacity in other places to allow them to actually go, I can do this, I can change what I'm doing, and I can take the time to step out of what I'm doing in my business as usual to think about innovation. I think big tech can pay for the resources to kind of plug those gaps. So if someone in the health service doesn't have the time or the capacity to do it, they might be able to kind of push their way in. And of course, they kind of lobby for those and promote their names always. But I think the smaller organizations don't really have that capacity or that funding to do that. So it creates quite an uneven playing field at the moment. So that you get a lot of big tech pushing their way in, where smaller companies can be doing that work, probably cheaper and probably I would say better than those big tech companies. But they don't have that capacity themselves to kind of backfill for the NHS, and they aren't able to survive financially while they're trying to wait to get contracted with or to help the NHS understand about innovation. So as Kendall was saying, it's creating that landscape to make sure that this can still thrive and we're doing something for them. I think one of the issues is about making procurement easier for them to navigate and slightly less restrictive. Because even to sign up to some frameworks, smaller companies struggle to hit that bar. And I think the Procurement Act came out and it was supposed to streamline procurement and help everyone within that space. But actually when you kind of looked at the underlying requirements of it, it did kind of place real barriers for smaller innovators. They just didn't hit those thresholds. So it's thinking ahead of time when, as regulators, what it is we're doing, what's that effect going to be on those smaller players in the industry. And we don't really want all our smaller innovators to be bought out by big tech and be taken somewhere else. So it's, as you said, about making the UK economy thrive. And we need to do that by helping those people on the ground who are coming up, the entrepreneurs as we like to call them, who are coming up with those really good innovations. And making them kind of sustainable until they're revenue generating, because they're not going to be revenue generating off the bat. They're going to need some sort of support to make sure that while they're getting to that place, they're not going to fold. And I think that's one of the things we've seen within the innovation space is these smaller players having to just stop because they aren't able to continue their business as usual day to day, pay their staff. So it's making sure that we're allowing that space for them, and this could be done through things like bridging loans, funding, making sure that we're paying them on time. I think that's probably the most important one. We see people not folding just because they can't afford to do their normal. And I think there's a lot of stuff out there, particularly I think we all talk about the potential of digital, and AI, and I think that's super important at the moment. And we have seen AI being used in really kind of simple but effective ways, and ways that we've been surprised about, or that if you spoke to the general public about, they would be like, oh, that's interesting. So things like Anya, which is a support app that helps mum their breastfeeding journey. You wouldn't think that AI would be used in that, but it's actually used quite extensively. I think if you mention to public AI, they might think, well, I don't want to use that. But it's about that kind of education piece and making sure that everybody out there understands what AI means and what digital means. And things like when you think about Anya, that helps with the analog to digital. There's things like Procom, which helps with the hospital community, and again, that uses quite a lot of AI to help domiciliary care. And then there's AbTrace, which does that kind of back office function that you mentioned. That's really quite important at this point. And that kind of identifies patients who are shifting from treating sickness to prevention. Again, helping on the kind of third layer. But it's not something that's really prevalent within the healthcare that people will automatically be thinking of. But you've got programs like the NIA, you've got programs like the HINS, you've got many innovation programs that can help people and the government spot these innovations. And I think within a 10-year plan, that's something that they should be thinking about, is we've already had these here. Let's not create something new, let's use what we already have. I think when you think about it though, there's a kind of a mixture of diagnostic and there's non-diagnostic patient-facing, and there's those really great back office functions, which I think will be revolutionary and have less chance of harming patients in the long run. But I'm always going to be slightly cautious about the kind of patient-facing innovations, particularly around AI, and whether I think we're at that place where we're ready for that, and I don't think we are. I think what we need to do is allow them to thrive somewhere or be used somewhere, but then we need to make sure that they're being evidenced really quite clearly and making sure that they're showing its efficacy and safety for patients, as well as showing the providers how to use those innovations and not be drawn in by the shininess of it or by the big name that backs them. Because that can be really easy for providers to think, it's being backed by Google, so I think we should use that above something else that probably has more evidence base. I think evidence needs to be kind of key in this space. And I think at the moment, the health landscape, I think we all know, is a bit of a Wild West. And I think since COVID, it's just gotten a bit crazier. And I think it's really hard for patients to understand what's good and what should be available to them and what they should actually use. I think we need to create a kind of public health education system where we're educating patients about what is good tech, what is good innovation, and that again has to be evidence-based, but teaching them what good evidence looks like, because you can have lots of evidence and you get kind of, it's so convoluted that sometimes when you're speaking to someone on the ground, it's not something that would be really clear in their mind, so they can be kind of bamboozled into thinking this is amazing. So that evidence piece needs to be really clear, that what it is you should be looking at when you're looking at tech and digital, and particularly AI. And I think the regulatory system right now, as I said before, it's not really up to scratch to keep up with this, that kind of evaluation piece also. And I think we need to be moving a lot quicker with everything, because things become obsolete pretty quickly, and the smaller tech gets taken over by the bigger tech or stolen their ideas. So I think right now, the things we're not putting in place are a regulatory system that supports the kind of rapid take-up and evaluation of those smaller players, and then they just get taken over. And I think, as I was saying about the patient thing, I think it's also about empowering patients so that they're educated, they understand what good tech looks like, but then they also understand how to use it themselves. So that moving from analog to digital is really important for patients being able to empower themselves, not having to turn up for an appointment, but able to do it in their own homes and in a way that's accessible and easy for them. We do need to consider kind of digital exclusion, etc., but that shouldn't be a reason for us not to do anything. We need to actually just rapidly start doing stuff and then evaluate to make sure that we're doing it right, but not just stop. And I think that's one of the problems that the health service has. We're far too risk adverse, and we think if we're not doing it perfectly, we shouldn't do it. And that makes innovators nervous to come into the health system, but it also makes it just difficult for them while they're within the health system to support the needs. I think one of the things about the UK health system, though, is the life sciences sector and the health sector are thriving. I mean, you may not hear that in the news, and it's because it's better to talk about doom and gloom, but we have world-leading institutions here, and we should be tapping into them to get things from their lab pushed out throughout the health service. One of the issues that you will find, though, is that there's not a joined-up approach to that. And maybe with the 10-year plan coming out, we'll get that joined-up approach, and we'll get that. And now I'm personally really looking forward to it. I think just in general, I'll end with just saying that we need to think about procurement and the levers that and the barriers we're putting in place for innovators. And we think generally about how we support those innovators through funding and just any kind of support we can give them so they can continue to thrive. And then about empowering patients. There's kind of 3 things I really think will help with those kind of 3 big shifts.
Thank you, Mindy. And I think the power of putting the patient at the middle, I know you're really passionate about and have spoken about quite a lot, and how we design around that. Super interesting. I think a couple of things that have just come up in your reflections. One is about definitions. So as you say, innovation, really broad term, means different things to different people. It could be a change in who delivers what. It could be a change in staff mix. It doesn't have to be new jazzy technology. And I think that's a really important thing to hold on to as we're talking about digital solutions, also thinking about wider innovation that might need to sit within. I think that extends to AI. What do we mean about AI? And I know in our RSET team, we've been having a lot of conversations about this. What's the problem these different solutions are trying to solve? When is it actually a regression model? When is it actually a piece of software? And just trying to get actually underneath the bonnet of that terminology. And digital is another, which we use quite loosely, but actually has lots of different meanings. The other thing I wanted to pick up on is your theme about market entry and market exit, because I think what we have observed across the NHS is that we've got major tech giants. Microsoft is in pretty much every provider, and then we're quite good at testing things. So we have lots of sort of 5 different sites that are testing this and testing that and piloting this and piloting that. But a colleague of mine described it as, how do you support teenagers to become adults? We've got sort of lots of testing of children, they become teenagers, and we don't have a way of transforming them to get that next contract, as you said, to get that scale, and then they either stop, exit altogether, or they leave the UK and go and scale and spread elsewhere. And even some of the most successful companies like Sleepio, that I know is an NIA fellow, fantastic success on enabling digital to be prescribed, which gave them a funding route, actually ended up scaling by going to the US. And that feels like something that we need to tackle maybe in the 10-year plan, or how we implement it. But lots of sort of food for thought in your reflections, Mindy, so thank you so much. I'm going to pass to Sonja to share more about your reflections on how do we evaluate this.
Great, thank you. And I mean, just having listened to Kendall and Mindy and your comments, I think we could have a 10-minute talk just on this, because there's such interesting thoughts. But I will stick to the brief, maybe go off piece a little bit to pick up on some of the points that Kendall and Mindy spoke about. But yeah, I think what I'll primarily focus on is sharing some learning we've gained from the evaluation of tech-enabled remote monitoring in health and care and its implications for policy and practice. Really, with tech-enabled remote monitoring being a key example of digitally enabled innovation and very relevant to current policy directions and NHS reforms. So this is learning we've gained through the work of DECIDE, and I mentioned, just as a refresher, DECIDE is an NIHR-funded rapid evaluation center, and our focus is specifically on tech-enabled remote monitoring and associated tech-enabled care. Is delivered in partnership between the University of Oxford and RAND. And this is, of course, a key part of the policy vision that Kendall overviewed for NHS reforms, for a move towards more digitally enabled care, a focus on prevention, or at least prevention of deterioration and reducing unnecessary hospital admissions, and a key part of wider efforts to improve care quality and manage demand, not necessarily reduce demand, but manage demand for in-person services. So we're working across a range of projects broadly to do with tech-enabled care and remote monitoring. We've completed an evaluation of applications in COPD that should be published soon. We're completing some work in the hypertension space and in the use of home sensors in social care. And we've started 2 new pieces of work in the area of managing heart failure and the national evaluation of digital health checks, which I understand are now called NHS Health Checks Online. And I say that as context because it's relevant to some of the things I'll get onto shortly. So I guess from an evaluator's perspective, the evidence base in this space is evolving very rapidly. And there's a lot we know that we're learning about, but there are also really significant evidence gaps, with the devil really being in the detail of some of the learning points I'll talk about today. So there's quite a lot of diversity and nuance in implementation pathways across different clinical areas and geographies. This can be due to the have to do with the tech that's used and its functionalities. It can have to do with workforce organization and workflows, with governance, management, patient prioritization, and I'll come back to that later. There's also a growing number of tech providers with rather different offers in some ways, and all of them try to differentiate from each other in terms of what they can offer. So some are kind of one-size-fits-all platforms that do many things in the NHS and not just tech-enabled remote monitoring. Others maybe focus on offering clinical decision support. Then there are platforms and apps that can do things like patient recall. So really quite a lot of diversity. And there's a lot of talk in this sector about, well, what does that mean for the future? So if more and more things are going to be run through the NHS app, will that actually really improve scale? Will that really improve interoperability? Will different tech providers be able to plug and play with the NHS app? Or actually, might it be an impediment to adaptability and configurability? There are lots of questions around that I'd be very happy to come back to in the discussion. We also see interventions at very different levels of intensity, so from small-scale pilots or relatively limited efforts in areas like COPD, to somewhat more established practice in, for example, hypertension. And in primary care, and I think this is really important to reflect on, both in policy and practice looking forward, most of the focus in tech-enabled remote monitoring has been on single condition pathways. Now in acute care, in virtual wards, hospital virtual wards, we see some general virtual wards. But more and more patients that we're dealing with are patients with multiple morbidities. So there are important questions for primary care about how can tech and tech-enabled remote monitoring care for the needs of these more complex patients. There are also significant evidence gaps. There's very little compelling evidence. There are lots of case studies and kind of little bits and pieces of information, but little kind of systematized and compelling evidence on the impact on service utilization and also on cost effectiveness. There's some evidence that this digitally enabled monitoring can have a positive impact on service user outcomes or experience. So for example, pretty good evidence in terms of controlling blood pressure. But then weaker or more inconclusive evidence in other areas like COPD and managing exacerbations, or indeed in social care. So there's pretty good evidence that using, for example, home sensors for remote monitoring in social care can offer patients reassurance, but not that much evidence on what the added value of the tech enablement is for managing independent living. We also need more evidence on the impact of these technologies on carers and actually on the role that carers play in the system. This is a really, really important theme. And there's rather limited evidence on the nuances of implementation and how this affects causal relationships for spread, scale, and sustainability in the system. So in terms of what we're learning about the influences on the implementation, spread, and scale of tech-enabled remote monitoring, in the interest of time, these slides I assume will be shared. I'm not going to go through all of it, but just I'll highlight a few examples. And I think the key message here really is that the influences are highly socio-technical in nature and often interrelated. And I think to this audience, this might sound like a little bit of motherhood and apple pie. It's kind of obvious. But the reality is that it's the most obvious things that are sometimes the really, really hard things to make work in implementing service reforms and in implementing policy. So yeah, some of the influences relate to technology and supplier factors. So for example, the adaptability and the configurability of the tech offered to specific local contexts is really important. Some examples of that include the ability to personalize messages, inviting patients onto a service, to adapt how often readings for specific measures, heart rate, blood pressure, or others are taken for, how often patients are reminded, the ability to personalize what constitutes a normal threshold or an out-of-range reading for particular patient profiles. Those are some examples of tech-related factors. Interoperability and integration between remote monitoring platforms and NHS and social care IT systems is also a key issue. And actually, in many ways, that ability to plug and play is improving. But again, the devil's in the detail because there, for example, in primary care, there are big challenges related to how these systems kind of speak to connectivity with primary care PC gateways, or just challenges with automating and updating SNOMED codes for patient information and electronic health records, which GPs often still have to do manually. So yeah, then there are also health systems factors, such as system-level leadership buy-in and support, and really importantly, clarity on commissioning routes and criteria for commissioning these types of digitally enabled services. And a bit of a spoiler alert, but what we're learning about is that there's actually at the moment quite a lot of rather serendipitous and relational-based commissioning. And I'll come back to that when discussing implications for policy and practice, and how we can actually provide clear demand signaling, but that's not too rigid. Then if we look at patients and patient-related factors, clearly patient acceptability and trust in technology is really important for uptake and adoption, and quite a complex set of issues relating to history and culture actually affect that acceptability. And then, of course, the intersectionality of different inequalities, cognitive, cultural, social, socioeconomic, digital literacy related, will also really impact patterns of uptake, as will the involvement of informal carers. And I just wanted to pick up on a point that we've been talking about, kind of patient empowerment. This is a thorny issue, but I'm not sure that all patients want to be empowered and want to take more care of their own health. There are those who actually really want, doctors or clinicians to do that. So I think we need to think about diversity and inclusivity in quite a complex way. And then if we look at kind of health and care staff, clearly clarity in roles in pathway delivery is really important, including for non-traditional roles like receptionists and healthcare assistants, nurses, clinical pharmacists, digital care coordinators. These roles have really significant impacts on the delivery of tech-enabled care. And also this can also involve quite a lot of hidden work. And I think what is highly under-researched is where regulation comes into play in this whole agenda, regulation of novel roles, regulation of novel functions, within a flexible and structured framework for change and for delivering these services. And then finally, although I'm sure we'll come back to a lot of these issues in discussion, actually before I go into implications for policy and practice, another thing that was mentioned was AI. And I think what we're seeing, this field is evolving so rapidly. Technologies are changing so rapidly. We've used blood pressure monitors. Now there are companies offering promise of using a smartphone, looking at our blood vessels and being able to diagnose hypertension. What we're calling AI, we're often actually seeing a lot of use of pattern recognition, machine learning, not really AI. But also the AI is only as good as the data that it's trained on. And there are some areas where we have better patient data, or clinical data, and some areas where actually that data is pretty weak, and where I think what we've learned through a wider portfolio of work on evaluation and innovation is that if the tools are there, they can impact on the exercise of clinical judgment for very, very busy staff. So I think there are questions around how we manage risk in a system where we use technology and use these tools in safe ways and in good balance with clinical judgment. And yeah, I'll conclude with just some emerging implications, policy recommendations from our work so far, just a taster, whistle-stop tour. So if we look at pathway design, the design of digitally enabled care pathways, I think the key message here is really that there is no one-size-fits-all approach. There are some things that can be fixed and represent a more overarching structure, so different stages in delivering these pathways, like patient identification and awareness raising, or recruitment, onboarding, monitoring and management, and potential offboarding. But the way that that's delivered is always going to vary in terms of different contexts, be that in terms of the tech used, the workforce. Sometimes you see models which are very much led, I'm talking primary care here, but led at a GP practice level. In other cases, you see models of delivery that are led at a more centralized kind of PCN, ICB level, different workflows, different ways of prioritizing which patients can get access to these services, also in the context of affordability. And I think when we look at different governance models, especially if we're thinking about scale and spread, there's significant trade-offs between autonomy and control that come into play in these governance decisions. And so quite a lot that needs to be thought about in that regard. In terms of inclusive design, I think it's important to flag that tech-enabled remote monitoring will never work for all patients. There will always be patients that can't engage digitally, and really what's important in designing these services is to think about how term service, technology-enabled remote monitoring services, And more traditional services can run in parallel within a particular workforce architecture. And to think about where's that tipping point where actually we have a sufficient number of patients that are on tech-enabled pathways that makes this cost-effective. There are also really important questions around dealing and how these services can cater for patients with multimorbidities, and particular evidence gaps in the integration of tech and digitally enabled care across primary and acute and home and social care. When we look at planning for delivery and for implementation, I think it's important for policy and practice to consider how using technology will change the relationship between patients and providers, or patients and staff, and between staff themselves, because in many ways, it can shift the onus of responsibility sometimes from the NHS towards patients taking action for out-of-range readings, depending on how the service is organized. It also has implications for staff. Demands on some sort of staff will decrease, maybe face-to-face appointments for GPs, but demands on other types of staff and activities can increase, like digital onboarding, receptionist time, nurse time. So I think that needs to be considered alongside hidden work. And then finally, when we think about scale and spread and reflecting on what we're learning, what works for implementation and sustainability in one context may not be fit for purpose for a more scalable model where governance and the role of the center and the role of regions versus organizations might differ. So I think it's really important when we're rolling out neighborhood-focused health services and place-based digitally enabled care to have good clarity on what the roles will be at organizational, local, and national levels, and how these levels in the system will coordinate and collaborate with each other on matters such as data governance, clear demand signaling, clear commissioning frameworks, workforce delivery, resourcing of services, and other areas. And I could go on forever, but I will stop.
Thank you, Sonja.
Thank you.
That's really helpful, thank you. And I think that point about the different roles of the different layers of the system, obviously last week we saw the model ICS, and we saw some emerging guidelines around what are going to be the decision powers at the regional level. So this is obviously all quite dynamic and changing fast, and no doubt something that you'll be thinking about with the 10-year plan. The other thing it's great to see you highlight is about the role of carers, and that feels like an ongoing discussion about how do we empower carers to be part of our workforce and recognise the caring role they have. I think we know from an academic community that they have a very powerful role as advocates, but we've done much less in empowering them as members of our care circles. And for 25 years we've given patients access to educational tools so that they can take self-management into their own hands, and we haven't done that for carers. We've left it to a very scattergun, I guess, voluntary sector. Not that what they're doing isn't great, but it's not consistent. So lots of themes that have come up. I promise this to be a conversation with all of you and our panel. So hopefully the content that Kendall, Sonja and Mindy have brought to the room has sparked some questions. We've got some roaming mics. I'm looking up the team. Brilliant, thank you. Roaming mics got their hands up. So if people want to put their hands up, we'll just take a couple of questions at a time. Brilliant, we've got one just there. Thanks.
Hello, thank you very much. So I'm Dr. Elise Parkinson. I'm from Health Innovation East. Mindy, you spoke about definitions, the definition of innovation, but particularly around AI and what public awareness is, around AI. At Health Innovation East, we did a research study last summer about the kind of deployment of a particular AI tool used in primary care. And as part of that, we were looking at the acceptability and public awareness of AI use in primary care data. And what we found is unanimously, the public are not aware of this practice. It flagged a lot of concerns, understandably, from patients. But deeper diving into the conversation was around actually people have their own boundaries on what is acceptable, for what conditions it might be acceptable, but quite supportive if they were made aware. As you probably know, GDPR says that providers should make patients aware of this. I don't think this is probably happening in practice. What are your thoughts? How do we raise awareness to the public of this practice so that it's less scary for the public?
Thank you, really important topic. And I know that one of the sessions today is about the RSET programme of evaluating an AI tool in chest diagnostics. And one of the key bits on that is, are patients aware that this is being used? So really, really important theme. Any other questions that we just want to gather a couple at a time? Yes.
Hi, I'm Dr. Leah Ali. I'm a consultant psychiatrist and a healthcare and design clinical advisor in NHS England. My question was Dr. Marjanovic. I hope I've said your name correctly. It was just about, particularly from behavioural science perspective, you mentioned patient empowerment, and I just wondered how you think about logic of care and patient activation measures in terms of thinking about how we deliver digital interventions. And that kind of thinking about that piece of what patients actually need and want.
Thank you. Other questions? So while you're still thinking, Mindy, do you want to just come back on how do we raise awareness of AI being used in services? And then perhaps Sonja and then maybe Kendall around that patient empowerment.
I don't think you can leave it to service providers to raise that awareness. And I don't think it should be something that's only provided at the time of use. I think should be something that we should be consistently pushing out to patients. So we need to create clear guidelines, and I imagine Department of Health, Office of Life Sciences, etc., can do something like that, about simply a basic thing of what is AI and the type of things it's used for. It can sound really scary. I mean, generally, even to me, if somebody says to me, we're using AI to do this, I'm like, well, what are you using that for? You know, and I think it is an education piece, but it's not an education piece you can do in 5 minutes. And I think we need to make a long-term plan for that. I do think there's an issue where we seem to expect people who've not used certain technologies to just jump on board. And I don't think that's realistic. I mean, we're all kind of set in our ways. So I think what we should be doing is not just the people now, but we should be doing it for people before they become patients. So before, when you're in school, when you're growing up, you should be getting information about what is AI used for, and not just in health. I mean, it's used in so many different places. So I think relating it to health is always slightly more scary because your health is like such a big thing. But if you put in context, AI is used every day in so many different ways, and you kind of translate that and make it a little bit more obvious that it's not as scary as it is, I think that's quite important. So put it into like the whole picture. But I think that whole picture needs to be provided to people all the time. So I think a public awareness campaign, or every time somebody turns up with their GP explains really in detail what's being done with it. But I think just making sure that people are primed to want to embrace it in some way. I think that's the only way it can be done, but you can't leave it at a provider level. They don't have the capacity, sometimes they don't even have the knowledge to do it. And that's not insulting them in any way, because you have your specialties, and sometimes you just need to stick to that, and you don't necessarily have the time to be engaging with it as much as you want patients to. So I think it needs to be something that's kind of pushed out throughout the nation in every aspect.
Thanks, Mindy. Has this come up in the public conversation on the 10-year plan alongside putting health ministers into cannons? Has anyone talked about AI?
So we have asked about that sort of area. I think what's come through is that people understand that AI has great potential and will be increasingly used, but what they expect is for there to be a human in the loop. Okay. So they want it to be kind of augmenting rather than replacing, which I think does beg an interesting question, as the technology improves in the years to come, where I think everyone seems to agree that in the next few years, kind of AI will be better than most people at most things, and especially when you're having these more kind of autonomous AI models available at really high performance for things like interpreting scans or whatever it may be, how you kind of align that with the public view that shouldn't be autonomous, whereas actually if it's much more effective and safer than the human in the loop, how do you square that circle? And it's an interesting question which I won't propose to answer.
Yeah, but the role of evidence and evaluation improving that is a really critical piece. Do you want to pick up about patient empowerment, Sonja?
Can do, yes, of course. So I think that's a really, really good question. And the biggest risk in the landing of all of this is if solutions focus or policy focuses on the structural and not so much on the behavioral and implementation aspects. I think patient activation has to be done in communities. There's only so much that can be done at a national level, and we're very fortunate. I don't know if Shabira is in the room. Hi, Shabira. But working with organizations like People Street, who are really embedded in communities that can understand people's needs, people's concerns, the levels, how they want to be empowered, how they don't want to be empowered. I think that's the key, really. I mean, it sounds like an obvious answer, but really community-based engagement. Focusing also on those who are likely to be most excluded from the service, because if we can make it work for them, then we can make it work for the majority. And I just had one tiny point on the AI question as well, which we're hearing a lot of what you both said, Kendall, as well. The other thing that comes up a lot, and you know, lessons learned from failed initiatives like Care.data, I think the public expects some transparency around risks and safeguards. And just like in other patient-facing resources, so not only talking about potential, but talking about what the risks are and how the risks are being managed is important in AI.
And just to pick up on that, I just wrote after you spoke about the fact that I don't think the regulatory landscape we have right now supports the use of AI in diagnostics or really that kind of patient-facing bit. I think it's great that it does the kind of back office function, and I think we need to make clear to patients that right now it's not necessarily going to take somebody's job, and it's not necessarily going to be the thing that diagnoses you without a human being involved, because I don't understand what the legality of that is anyway as a patient and somebody who actually works within that. And I imagine that's one of the issues that patients have, is they're thinking to themselves, well, if this machine decides for me that's what's going to happen, and a doctor hasn't seen it, and if something happens to me, is the machine going to be punished? And that doesn't happen right now. So I think we need to have that regulatory framework and a real discussion about what can AI really be used for.
Thank you, Mindy. Other questions from the floor? Yes, just here. Just behind you in the yellow top. Thanks.
Hi, I'm Hannah Rose Douglas. I'm the head of the Improvement Analytics Unit at the Health Foundation. I've only been in my job a couple of months, so one of the things I decided to do, thank you, first of all, was to try and figure out what the landscape was, what the evaluation landscape was around AI. So I have spoken to people at NICE, I've spoken to people at NIHR, I've spoken to people all over the shop. And what I've found is it's extremely chaotic at the moment. So the funding landscape is chaotic, but also trying to understand where and why specific types of technology go through the full NICE process, which ones have an enormous trial associated with them, and which ones just somehow get into the system under the radar. So just down the road here, there's the UCH, and I've spoken to their digital innovation team. They are fully funded by charity, so the charitable funding of the organization. So they are able to do business cases in order to get technology direct from companies into their processes. And the decision rule that they have is, does it save money? That's the only decision rule they're allowed to have. So that means whether it's good for patients, whether it's good for clinicians, whether it is cost effective, whether it has impact across the system isn't taken account of. So what we need, I think, is to come together as a community and to think about what's the wider framework around what is evaluated and how it is evaluated. Because at the moment, I think it is too chaotic, but this group, I think, perhaps with the Health Foundation with a convening role, can start to put together what that framework should look like.
Thank you, really helpful comments. And I think sometimes when you look at VC companies, for example, and how they evaluate the product market fit, the ROI, there are some quite interesting reference points that maybe we can build on out there. So that's a really helpful comment from the floor. Other questions for our panel? We've got a couple in the middle, thanks.
Oh. Can I just pick up on the comment first before we move on?
Go for it, Mindy.
Yeah.
She's looking.
So I was just going to say that, you know, when, from your point of view, it's chaotic. Can you imagine from an innovator's point of view? Is when they turn up in front of an organization, and that organization is they're saying, show me your evidence, and what they've done through their clinical trials and their piloting, etc., doesn't give the evidence that they need. So that framework is so incredibly necessary so that it starts creating a pathway for innovations to say, this is when you're piloting the information that the health service is going to need. You're not going to be asked for hundreds of different metrics that from different organizations, and it's not going to be chaotic that way. And then once you actually prove that, at some point, you will get funded. And I think that needs to be, first part needs to be a framework on evaluation. And it's not something, you're right, we do not have it there. But from an innovator point of view, they will spend thousands on getting those evaluations that will be useless.
Thanks, Mindy. And NICE have got a role in that, and I know are evolving quickly around what that looks like. Shall we go? Yes, thank you.
Susan Griffin, University of York. I just wanted to ask you about risk and whether that's how you evaluate that in the context, I guess, of more broadly, a lot of these tools and technology, people are using them outside of the NHS and they're being exposed to them without any kind of regulation. And how do you give capacity, I guess, within the health service to educate people or at least deal with the fact that people will be arriving having used these types of technologies? How do you, in regulating and approving technologies, distinguish between those that have been approved? And are you evaluating and communicating what the impact of NHS-approved new digital technologies are on risk, compared to, say, unregulated ones, and also compared to the existing status quo, because we know that systems without these new technologies are not risk-free. So is there a widespread understanding of the current level of risk in the system and how that's changing with all of these innovations?
Thank you, really helpful. We had two other questions in the middle. Yeah, thank you. I think at that point about risk and regulation, and also the expectations that might come when people then interact with the system if they've bought their own diagnostics, for example, and how we respond to that is quite a hot topic. Go for it.
Hi, good morning, everyone. It's Kerry Flett. I am a knowledge specialist from Hampshire and Isle of Wight Healthcare NHS Foundation Trust. It's been really heartening to hear the word evidence mentioned. It doesn't sometimes get mentioned in this context. In such detail. And I wonder if the panelists, from your experience, if you can tell us, what are some salient ways that you think evidence could be most useful in this kind of space, particularly around things like rapid evidence reviewing and realist reviewing?
Thank you. So a question about evidence and its role and where it can be most useful, and these evolving methodologies that we're using in rapid and realist evaluations. And then we had another question in the middle. Go for it.
Yeah, just about. Yeah, we should definitely link up. Sorry, I forgot your name. What was it? At least, yeah. Brilliant. And on the point of procurement as well, so I'm from the Department for Health, and just in terms of that framework that you were discussing, yeah, so in the Department for Health, we've done some research in the procurement space, around the procurement of medtech. And one thing that we found, yeah, a really, really cost-centric approach. And one thing that we're trying to do, which is outlined in the medtech strategy, which Subodh here is leading on, is value-based procurement, so trying to shift from that cost-based to that value-based approach. Obviously, that's extremely challenging for a number of reasons. For example, you've got, the funding model of the NHS. The procurement teams that we spoke to, they very much had that view that they need to keep costs down. That's what their manager's telling them, right? So I think the goal of value-based procurement, which might be that, that framework you were talking about, is trying to give a framework to procurement professionals to say, when you're procuring medtech, you want to be thinking about all of these aspects of benefit, environmental benefit, the wider patient pathway. Does this medtech save 4 minutes of nurses' time per use? So that's just maybe the first point, is on value-based procurement and trying to move away from that cost-centered approach to value-based. And then secondly, another project that we're leading on in the Department for Health is Compass. So it's trying to take all that value-based procurement information, so all the sort of evidence we're talking about, NICE, late-stage assessments, all the fantastic evidence this is out there in a disparate kind of way, and centralizing it so that, through that sort of SME lens. Currently, we have all of these SMEs having to provide data to all these different trusts multiple times. So what we want to do is sort of centralize that, so it's collected once, used many times. So definitely worth kind of connecting on that. But I suppose just a reflection from me is, yeah, procurement is very sort of cost-centric. And I think in that endeavor to sort of help SMEs, it's about centralizing it, collecting it once, and making sure there's a clear framework for procurement professionals so they can turn around and say to their financial director, this is more expensive, but you can use it 10,000 times. For example, tourniquets is a great example. So trying to unlock that long-term sort of value.
Thank you, that's really helpful, and those central frameworks and how that might build fluidity of being able to move across the system. Kendall, I don't know if you want to pick up this piece about technology being used that's NHS regulated versus not. Thinking about your NICE hat and obviously the key role that NICE plays in determining what is commissioned across the NHS.
Yes, so I suppose there's the pre-NICE regulatory stage where it sounds concerning that people are using unregulated diagnostics, so hopefully that is not too widespread. Certainly everything should have the appropriate regulatory status, which can be very light touch if it's not, directly shaping patient care. So I suppose there's something around there about understanding how widespread these things are. You do hear about innovative things coming through and being developed kind of software as a medical device, which actually the people developing it don't realise at all that it is a medical device, so they don't think to get it regulated. So there is a question there around awareness building, both among innovators to make sure they're aware that they have to get regulatory approval, and also amongst people who might be using them. And then I suppose there's the NICE lens, and we need to bear in mind NICE is never going to be able to look at it will only ever be able to look at a tiny proportion of the medtech market, including digital products. Even if we have massively expanded our program, so we look at now, I think, 23 times more digital therapeutics than a couple of years ago, but that still represents a tiny proportion of the market. And the main reasons why we can't look at more is because they haven't got any evidence. There's no way to do an appraisal on no evidence, even with our kind of early value assessment that can do things more at an earlier phase to give kind of conditional recommendations with evidence generation. So on the NICE side, it's being clear, okay, what's the most potentially impactful products for the health service, which has enough kind of credible justification that's going to be useful, but will probably still need further evidence collection, particularly in the digital space. And that should serve as a kind of a powerful signal to the NHS that these ones should be prioritised, but they're still going to have to use things that NICE hasn't looked at just because they can't look at everything. So then I suppose there's a wider evaluation evidence point. And I think that's the thing around also the value evidence, and to kind of demonstrate the benefit to systems so that innovators can make their case and be adopted where they're useful. And I think that's particularly kind of going beyond some of these products where they're kind of point innovations which basically digitize a certain part of a process which actually doesn't make sense to continue. I think it's much more interesting to look at the kind of transformative things where you're really redesigning a process based around a new digital tool to really demonstrate that kind of system change, whether that's shifting to care to community or transforming back office, whatever it may be. Those things are harder to bring in, but they're much more useful. So I think having evidence for those sorts of genuinely transformative innovations would be really powerful. And then there's things we were hearing about before around when it goes nationally, what can be done nationally to streamline that spread around the system, and what's going to remain to be done locally. There's definitely some thinking going on about the 10-year plan about trying to reduce the burden to the kind of not invented here syndromes. You don't have to go through the same process everywhere to help spread around.
Yeah, super helpful. And I think there is a bit of this rise in consumer health where there are products that are being tested that people are self-procuring, which aren't necessarily NHS regulated or approved. And I was reminded a couple of weeks ago about that lovely term VOMIT, victims of medical imaging technology, which is a reminder that sometimes if you go through a whole body scan, you might find something that actually doesn't impact your health, but you then may feel obliged to respond to it. So I think there's quite a lot in that consumer health space that we need to keep up with, I think, in terms of NHS regulation and the impact that can then have on surges of demand of the population self-seeking some of these diagnostics and then wanting to know what to do with it.
Actually, we're hearing about the Apple Watch, it's registered in the FDA as a medical device, not here, and there's lots of people turning up to NE saying, my watch is saying I'm a heart attack, and they're not. So there is a question, like you say, around reducing demand and how you can, what the appropriate interface is with it. You think longer term, some of that data, citizen-generated data, will be a valuable source for the NHS, so it's finding the right way so that can be brought into people's care records, but to inform care decisions, but not in a way which is, driving inappropriate activity.
And could be really interesting data that we incorporate into our evaluations as well, so don't want to knock that. Mindy, do you want to say a couple of things about the procurement or your reflection on that sort of procurement framework that we have in the middle?
So I love the idea of what you're doing, and I want to speak to you after anyway. But one thing that kind of just flagged up in my head, and I don't think anybody's kind of mentioned, is that we can have this procurement framework, we can have really great evaluation, but the funding mechanisms with the NHS, within the NHS don't support those procurement kind of frameworks. They,
Because value-based is whole pathway and we're still quite segmented.
Yeah, exactly. Everything's really segmented. If you're looking at an innovation within cancer has to pay for it, even though at some point they may not be the ones who benefit from it. The savings might be technically down in the primary care or later on in some way in imaging, etc. And right now, we find and we have seen that certain areas within healthcare don't want to procure certain solutions because they're not the ones seeing the benefit. And that is a really perverse incentive right there for people not to procure innovation, because they're not thinking to themselves, my budget isn't going to be helped by this. So we need to, while we're looking at the procurement framework, we need to think about how does that funding translate across, and making people think to themselves, okay, yes, I'm not saving on it, but somebody else might save on it, and how do I help them save on it? It's almost like, I don't know if there's a way of like quid pro quo of your budget will save, so maybe you give me back some money. I don't know what it looks like, but right now it doesn't work because it's really siloed. So I love the idea of the procurement framework, but I want to see the money following it.
I think some of that was the original stimulus behind integrated care systems, wasn't it? But we will leave that for the 10-year plan to solve. Sonja, do you want to share some thoughts about evidence and these different forms of evidence and evaluation, and when different ones might be appropriate or not, to our question in the middle?
Yes, I'll do my best. I mean, I think I'll start by saying that when we look at rapid evaluation, it can mean many things. It can mean being rapid in terms of setup and getting evaluations going. It can mean being rapid in terms of methods used. And I think on the methods front, we often see traditional methods being adapted for a rapid evaluation context. So instead of a full-blown systematic review, you might do a rapid evidence assessment or a more targeted review. Instead of, full transcripts for interviews, we might end up doing RAP sheets, rapid analysis protocols. I think that's what it stands for. And on the quantitative data side, what we're learning in rapid evaluation is that, the landscape is really, really challenging. A lot of the data isn't there, specifically on service utilization and impacts. So we have to improvise, and what we've been doing, at least through Decide, is identifying where we can't do a full-blown rapid quantitative data analysis. We try to suggest what data would need to be in place by the system, so almost formative value in order to be able to collect that data. But I think the one other thing I'd like to flag, or two things really about rapid evaluation and methods. I think often when we do evaluations more generally, we're really going deep and we're asking, what an intervention's like, how it works, how it relates to the external context, what the enablers and challenges are, and so forth. I think in rapid evaluation, there's something around getting closer to what the biggest bottlenecks, stumbling blocks, and areas of uncertainty are, and thinking about how you address those. And my reflections on the work of Decide, and colleagues might want to chip in, is that isn't only about using rapid methods for evidence generation, but it's also about educating, with a small e, commissioners and clients of rapid evaluation to better specify what the evaluation needs are. So for example, we've been working quite a lot with our clients and commissioners around what is it that you really need to know? and I think if we can get that right at the start and really identify the gaps and bottlenecks to focus on, then rapid evaluation will have even higher value.
Thank you.
Very, very quick one on the regulation point, if I could just chip in really briefly. That's come up quite a lot, and in addition to what you've spoken about, Kendall, innovators often, the possibilities of technology are greater than how technology is being utilized. So it's not unusual to hear suppliers saying, technologically we can absolutely be offering clinical decision support, but the bureaucracy of the regulatory process to get that class of approval stops them from doing it. And I'm not necessarily advocating or arguing that doing it would be a good thing, but I think it is something to think about, because the incentives in the system and how efficient our regulation can be will affect the potential of the tech.
Thank you. I think we had just a final question. Arnie, do you still have a question you want to share with us? And then my role as the chair is to make sure you all get to that nice courtyard with your drinks, so I'll do that after.
Yeah, thanks very much. So I'm Arne Walters, Head of Improvement Analytics at Cumbria, Northumberland, Tyne and Ware NHS Foundation Trust. I just wanted to jump on the conversation around sort of there not being a clear pathway for innovators and understanding what evidence they need to present at different stages. I guess want to make a plea to make sure we don't go off and sort of develop more frameworks, because there's quite a few people have been trying to cover this, in particular in the Health Innovation Network. There's been a lot of work along this, working with innovators to help them understand what's needed. So in particular, I wanted to point you to Health Innovation Northeast North Cumbria is aptly named Innovation Pathway, which sort of sets out the various steps and gateways, and they've got quite strict, I guess, sort of tests when they think an innovator is ready to move on. And I'm sure that can be developed further, and maybe that needs sort of work to be adopted nationally. But I think there's a real great starting point there to take off from.
Thank you, and that's a really important point, that we're not starting from scratch. And Mindy, you're co-located with UCL Partners, one of the health innovation networks, so no doubt are keen to build on those existing tools and thoughts that's happening across that network.
Absolutely, and I think you're quite right. Within the health innovation networks and within just the wider landscape, there's so much work that's already being done. Great if they could all be joined up, because I know there's quite a lot of players in each of those. But what actually needs to be seen, though, is all that thought that's put into it is actually executed. So you can tell an innovator this is the kind of pathway. That pathway doesn't actually exist. That what it is, I think people create the idealistic pathway rather than what's actually happening on the ground. So they can show that evidence, they can be evaluated within all these various pilots, etc., but then they're still not procured in the end, even if they've shown that, you know, what we have considered is good enough evidence. So you need to create the environment and the funding system or the incentive or whatever it is for actual organizations to say, you do this and we will take you on. That's definitely not happening. And in fact, towards the end of even a really successful pilot, you will get innovators who will be just dropped in the middle of a commission, and thousands of patients will be affected, but it's simply because the funding isn't there.
Thank you, Mindy. Well, not to end on a downer, I think what we're reflecting overall on our panel is there's a huge role for evidence creation and evaluation, and that fits throughout the pathway. Yes. There's no one linear process of doing that shift from analog to digital. It's going to take lots of different fractions across the system. There is some optimism to come potentially in June. We look forward, Kendall, to more details on the 10-year plan. And Mindy, you continue to learn and evolve with your cohort of fellows about how can we get that piece happening. And it's great to see us sort of utilising new models of evaluation to actually build those different forms of evidence, depending on what the different conversations are and the different decisions that need to be made. So I'd love you to all join me in thanking our panel for kicking off today's event and for their kind and thoughtful contributions. Thank you.
So I'm going to really cheaply add to Jenny's optimism and say that the fact that we're all in this room shows that there's a willingness to do better. So that is the optimism we should be holding on to.
Thank you. So over to drinks, and do make use of the courtyard. Thanks, everyone.